will examine the sensory system. Sensory system examination includes superficial sensation, deep sensation, and cortical sensation. For superficial sensation, we will examine pain, touch, and temperature. The pain sensation we will be examined by a disposable pin, and we will start by asking the patient if he feels in a normal area that he didn't complain of. حاسس الشكة دي؟ حاسسها؟ تمام؟ دي كده ودي سليمة صح؟ حاسسها كويس. هشكك في رجلك وتقول لي حاسسها زيها ولا أقل؟ طيب دي زي دي؟ زي بعض؟ أجمل شوية. طيب حاسس دي؟ كل ده زي بعضه؟ طيب اكشف بطنك. طيب كل ده حاسه؟ حاسس هنا؟ طيب هنا حاسس زي هنا؟
لا اكتر.
طيب والاحساس كده كله محسوس كويس؟ حاسس كده؟ طيب we will compare both sides with each other. We will have some patterns. If we have some patterns of decreased sensation, for example, if we have glove stocking and glove hypothesia, this occurs with peripheral neuropathy. If we have certain root affection, for example, L4, L5, C6, C7, this is a radicular affection. If we have hypothesia during all over the lower part of the body and starts sensation from this area and upwards, so this is a sensory level which occurs with spinal cord lesion. If we have multiple areas of decreased sensation, this occurs with polyneuritis multiplex. So peripheral neuropathy manifests by glove and stocking hypothesia, radicular sensation with root affection, sensory level with spinal cord affection. These are the patterns we are looking for during sensory examination with the pin. And we will do this the same using a cotton. حاسس دي كده؟ طيب حاسس دي زيها؟ طيب دي زي دي؟ طيب الإحساس كده كله حاسه كويس؟ كده؟ By the cotton we will examine the touch sensation. Usually pain and touch are carried by the spinothalamic sensation, by the spinothalamic tract, and they are affected with each other except in one case only, where we have dissociated sensory loss. And this occurs with central lesions of the spinal cord, because the fibers that affect pain are intact while the fibers that affect touch are affected. So when you find that the patient in a certain area, for example from here to here, doesn't feel the touch but feels the pain, this indicates there is a syrinx or central spinal cord lesion between dorsal 10 and dorsal, for example, 5. And this occurs with Syringomyelia. Lastly, we will examine the deep sensation. We examine the superficial sensation, then the deep sensation. To examine the deep sensation, we will examine joint movement, joint position, and vibration sense in the upper limb and lower limb. So we'll start by joint movement sense in the lower limb. We will fix the joint here, the proximal joint, and we will move the interphalangeal joint. بص كده صبعك لتحت، كده لفوق، كده بيتحرك، كده ثابت. لما اقول لك كده تقول لي تحت، كده هتقول لي فوق، كده هتقول لي بيتحرك، ولما اسيبه خالص يبقى ثابت. I'll describe what I'll do to the patient. First I'll tell him that this is downward, this is upwards, this is moving, and this is not moving. طيب كده ايه؟ وكده
كده تحت
وكده
تحت
كده
فوق
وكده
تحت
كده تحت
في النص
كده
تحت
وكده.
فوق.
And we will do it several times to ensure that the patient can feel it well. This is called the joint movement and joint position. Position is upward or downward, and the joint movement, that is it moving or not. So joint movement, joint position, and vibration sense. The vibration sense, we will use the tuning fork 128. We will tap on the fork and put it on a bony prominence in the forehead here. حاسس الزنة دي؟ طيب. And we will put it on the medial malleus. حاسس كده زنة؟ حاسس كده؟ طيب حاسس كده؟ طيب. So if the patient feels here, so the deep sensation that is carried by the posterior column is intact. If the patient doesn't feel this at the medial malleolus, we are aiming to see if this is a peripheral neuropathy or a spinal cord lesion. If the patient doesn't feel here and the anterior superior iliac spine, he doesn't feel, and he feels it on the ribs or on the clavicle, so this is mostly a spinal cord lesion. But if he doesn't feel it here and can feel it at the anterior superior iliac spine, it's mostly a peripheral neuropathy. Then after the deep sensation, we will examine the cortical sensations. The cortical sensation is simply what the cortex has more to feel than the peripheral sensation. Usually the sensation passes from the lower limb to the spinal cord and crosses to the other side, passing first to the thalamus as a first relay, then the cortex as the last relay. The thalamus can feel, but the cortex has more complex functions. So the cortex can feel and the thalamus can feel, but the cortex has more delicate feelings that can feel where did I point exactly, so it's called tactile localization and two-point discrimination and stereognosis or graphesthesia. First, tactile localization. I will ask the patient where exactly I'm touching him. عايزك while closing his eyes عايزك تغمض عينك. لما هشكك في حتة شاور لي عليها بالإيد التانية. This is tactile localization. Two-point discrimination. بص I'll describe for him. دي شكة واحدة، دول شكتين. تمام؟ عايزك تغمض عينك كده. I'll do now two-point discrimination. هتقول لي دي واحدة ولا اتنين. And I'll ask him if he feels one or two pain pricks.
2 1 1
When I come very near to each other, he can feel it in some areas, except the hand, he can feel it one pain prick. For example, when I come very near like that, he feels it one only. But here in the hand, افرد ايدك كده. اثنين. He can feel two pain pricks because the hand has very large areas in the cortical representation. طيب كده 2. So this indicates that he has intact cortical sensations. This is tactile localization and 2-point discrimination. The last one is stereognosis. I'll ask the patient to know something, an object from its texture. For example, I'll put him this in his hand and ask him what's this. خليك مغمض عينك كده. اللي انت ماسكه في ايدك ده ايه؟ اقفل عليها كده.
آلة كنت شغال بيها حضرتك، اللي هي بتاعت اللي هي فيها زنة.
الشكر ان انا لسه كنا ماسكينها. تمام. I'll put him another thing.
صابون. ده جهاز.
جهاز ايه؟
جهاز سكر.
مفتاح.
مفتاح عربية.
مفتاح عربية. تمام. So he can know the object from its texture, and this is called stereognosis, and this indicates intact cortical functions. So the cortical functions are tactile localization, 2-point discrimination, and stereognosis. Of the sensory examination, we should conclude what's the problem. We have either peripheral neuropathy, and this may present by glove and stocking hypothesia. We may have an affection of a single nerve, and the distribution of affection, for example, in the ulnar nerve will be in the distribution of the ulnar part. We may have a root radicular affection, and this usually affects a single radical. So now we should know the sensory distribution of these radicals. In the lower limb, this is the upper thigh is L1, the middle is L2, and the lower third is L3. Then L4 is in the medial part of the leg. L5 is on the lateral and dorsum of the foot. S1 is on the plantar part of the foot and the back of the leg. L2 is on the back of the thigh, and L3, 4, 5 are around the saddle-shaped area. Dorsal 10 is at the umbilicus, dorsal 7 is at the lower costal margin, so D7 is here, D8, 9 are here, D10 is here, L1 is here, so dorsal 11 and 12 are above the inguinal ligament, below is L1, Above the costal margin D7, at the nipple line D4, so D5 and 6 are in between here. D4 is at the the nipple line. The sensory distribution here is D3 and D2. C8 is on the medial part of the arm. Dorsal 1 is here. C8 is on the medial part of the forearm, C8. C7 is in the middle finger and an area above. C6 is the thumb and the index finger and a part of the forearm. C5 is on the lateral part of the arm. C4 is here. So dorsal 4 on the nipple line, dorsal 3, dorsal 2 is here. Then C4 is above, C3, C2, and then the trigeminal nerve. This is the distribution of the sensory area. And these are called the dermatomes. We use them to know if this affects a radicular sensation of any radical in the upper or lower limb or not. If the sensation is lost in one limb, so this is a plexus lesion. So if I have an affection of one limb, this may be a plexopathy or brachial plexus lesion. If I have an affection of one part, the right side, upper and lower limb, the affection may be in the cervical region on one side. If I have affection of the lower part of the body, the affection may be in the spinal cord. If I have an affection in one side plus the face, the affection usually is in the internal capsule of the other side. If the affection affects only the area of C8, for example, this is a radical, so the affection is in the root of C8. If the affection is glove and stocking, this is a peripheral neuropathy. If the affection is on the area supplied by the radial nerve, this is a single nerve affection. If I have patches of different nerve affection, this is called polyneuritis multiplex. That's all.